But right now, I'd like you to join me in welcoming Chacku Mathai, who's well known to many people in the room for all sorts of reasons, including that he used to work for us years ago, but he's gone on to at least bigger things. I don't know if they're better things, but he's a dynamic speaker. We've enjoyed learning from him in the past. I think he even won one of the medals one year for best performance. You didn't get the medal? Well, we'll talk to Ann about that afterward. But he's done so many things that I had to have a short version of his bio, but he can fill in the others because he really has been a person with a tremendous amount of energy at the vanguard of a lot of things in this interface between substance use and mental health issues. So he is a recognized thought leader and advocate about recovery and cultural competence, peer services, employment, economic self-sufficiency, integrated care, and services and practices in this area. He's been at it for nearly 30 years, even though he doesn't look a year over 30 to take a peek at him. He currently serves as the director for the NAMI STAR Center, which is a national technical assistance center on consumer peer-run programs funded by SAMHSA, that's part of the U.S. Department of Health and Human Services. He was formerly the Associate Executive Director for the New York State Association of Psychiatric Rehab Services and Implementation Partner for the New York State Center of Excellence for the Integration of Care. And so we welcome him back enthusiastically. And I'm sure it's going to be a fun ride this afternoon, and we'll learn a lot. So welcome again to Rochester Regional.
So every time I shake someone's hand, it hurts because I strained. I have that lateral tendinitis in the elbow. It's either called tennis elbow, depending if you play tennis. I'm an archer, so it's called archer's elbow. I'm trying to keep up with my 7.5-year-old daughter who can shoot archery 300 arrows at a time. And it's a beautiful thing to see, but I can't keep up anymore, you know. So I'm glad to be here. Thank you for the introduction, and thanks for involving me. This is an honor. When Terry and Ann and others started bringing this conversation forward, I was very excited, and I'm glad to see all of you are here to talk about it. So, you know, what I'm going to do is I'll probably do a number of things. I want to get into the evolution of this conversation around harm reduction. Excuse me. Thank you.
Excuse me.
Oh, you want to get the presentation up?
I do it like that.
Yeah.
There you go.
Perfect, thanks. So about this conversation between harm reduction and abstinence-based recovery models, and you know, the premise here is that there's a couple worlds to bridge, and the idea behind this conversation is to talk about what the opportunities have been around that bridging, what's happened across the country, or in at least some parts of the country I'll tell you about, as well as some of the kind of shared interests, some of the challenges, and maybe some recommendations for Rochester moving forward. So if you want to consider this further. I'm very curious about what brought you to the room, for example, so we might take some time for a little bit of that as well. I have a lot to share with you, so I'm going to try to balance that with how much information I'd like to make sure you have as well. So as was just said, you know, I've been around here in Rochester for a little while. Then I moved to Albany to work with NIAPRS for about 10 years, and then came back about 5 years ago. I am a person myself in mental health and addiction recovery since December 1985, and since that time have been very involved in developing with my family alternative supports for people, especially for young people. So myself, you know, I started I started when I was 15, right? So the idea of really supporting young people to be engaged in recovery in high schools and colleges, to be able to consider lifestyle changes at that level, and to address health issues that are considered chronic and long-standing in families, and to break those cycles, right? So a lot of that work, the STAR Center we're actually bringing in this year, I'm very excited. In this next grant cycle we just got funded for, we're now supporting a number of states and territories: New York, New Jersey, Puerto Rico, U.S. Virgin Islands, as well as Region 6, which is Arkansas, Oklahoma, Louisiana, New Mexico, and Texas. And in all of those states, we're supporting the development of organizational infrastructure and sustainability efforts for peer-run and family-run organizations. So what are those organizations that are grassroots, needing to bring the voices of consumers and families forward? We're trying to help build that infrastructure so those organizations can exist and continue. Nationally, we're supporting youth leadership and young adult leadership, so we're very excited about that. So this idea is to really highlight and stitch together all of the initiatives around the country that are really bringing young people forward to really takes, from a successive leadership perspective, right, to be part of the workforce, but also to be leading the movement. And really, what does it mean to really have young people at the forefront of change? So that's very exciting. And so if you want more information about that, I wish I could tell you more now, but it's go to consumerstar.org. That's our website. We just redesigned it. It looks a little better than the stuff we had up there before. I'll be repopulating it. I'd love your feedback. We're going to be doing a bunch of podcasts, and we have a YouTube channel and Twitter and Facebook and all the social media kind of stuff that we're all getting into. So I'm excited about that too. All right, so let's start with why you came here to talk about this. I'd love to hear both from the satellite sites. I'd like to greet the satellite sites as well. So if you're bringing in some text, let's start the practice going right now and see if it can come through from at least one or two other sites. Anybody in the room want to take a shot at why you showed up? You thought you were just going to sit around and listen to me talk, right? What's your name, sir? All right.
Work a lot lately with opiates especially, and when it comes to the harm reduction piece, a lot of our opiate users will have substance use in other areas, but don't seem to be experiencing harm from those other substances. And want to stop the opiates, but don't want to stop the opiates. So trying to find that balance, it's something we're not doing now, but maybe in the future to take a look at it.
Okay, so you're finding yourself working with people who are coming in regarding their opiate use, but not necessarily wanting to stop other substances. So this abstinence from all drugs idea is something they're struggling with, and you're figuring out how to engage them, is what you're saying. Okay, great, thank you. Anyone else? Yes, up there, thank you.
I was just wondering, this has been talked about for quite a long while. Rochester, we've done some education on. I remember back 10 years ago doing a lot of stuff, and it seemed to kind of fizzle out. So my reason for coming is, what is the status now and what's the philosophy now? Because there was a lot of time and energy put into co-occurring disorders and stuff like that, and then it seems like I don't hear it anymore, and I was just wondering where it went to and what's up with it.
I can explain some of that. I mean, there's definitely, so the question was, or the interest is, what's happening? It seemed like 10 years ago there was some drive towards both integrating care as well as looking at how to best engage people who are in more complex circumstances like this. And so we were wondering where, how that, has it fizzled out? Is it still going? What's the interest right now, right? Okay, got it. I should be able to address that. Any others? How about from the satellite sites? Any texts or emails coming in? All right, we'll stand by for that. Yes, sir.
Dan told me I had to.
You had to come. Okay. So now, if you are one of the people here simply out of compliance with a CEU requirement or a supervisory requirement, you now can relate to those of us who've been on paper for many, many years. Right? So the idea behind a compliance kind of approach is maybe it got you in the room. If something works for you, great. If it doesn't, tell me about it later and we'll work it out. I know. But I'm glad you brought it up, though. I can also throw in some other topics if you're interested. All right, so I think I got to use the mouse. Is that it, Ian? Oh, no, right here? Okay.
One sec. You're fine.
Okay, so there's like an X where I'm allowed to stand. I'm not used to that, right? So we'll see how that goes. Is it set? All right, so one of the things around the backdrop and the policy backdrop, I actually used to present on this at the beginning, prior to healthcare reform being passed in this country, and the reason why healthcare reform was even being considered. So let's just kind of, we're kind of in the same spot in some respects. We still have major economic crisis. We've made some progress in that regard, but there's still global, national, state economic crisis happening. We're still facing incredible institutional costs that are still rising, healthcare costs that are still rising. I mean, an example of that, $2.5 trillion dollars a year was what we were spending in this country alone, and that was, maybe 10 years ago, so it's still going up. It hasn't been reduced quite yet with what we're doing now. Prevalence of chronic illness and disability, 1 in 4 people in this country still have a person with a disability in the household. 1 out of every 2 of us have a chronic illness that we're facing, maybe even more, multiple chronic illnesses that we're managing, having to see 6 or 7 doctors at a time, multiple medications, multiple practices that are not necessarily going away. Impact of unemployment and poverty, let's just kind of focus on those of us with psychiatric histories, for example, 85 to 95% unemployment rates that are dramatically, continuing. Add to that people with co-occurring addiction and mental health issues. Add to that poverty rates that are happening. We know here in Rochester alone, a significant poverty rate that's reached, the top 5 in the country, especially for childhood poverty, and then homelessness as well. So we're struggling with a lot of issues, including racial, ethnic inequalities, and I'm going to get into some of that as well, and a major workforce crisis. So in terms of what does it mean to have a workforce development policy and public policy nationally and in the state that actually addresses all of that? Well, one stop in the process was to look at healthcare reform, and the drivers that you're starting to see actually play out in healthcare reform have to do with things like integration of physical health and behavioral health care, right? So you're seeing major efforts in that regard. You're seeing a greater priority for coordination and financing that's supposed to drive that coordination. You're seeing financing that, such as home and community-based service waivers and things like 1959, other kinds of initiatives that are happening right now, right here in New York State, that allow for a more community-based, integrated, flexible set of services. So again, the idea is to get out of these silos that we've been in from a funding and practice perspective, and to look at how to help people move from high-cost institutions and crisis services and be more engaged and successful in the community. Prevention and promotion of wellness have also been a priority in healthcare reform, so redefining what we mean by prevention. So it's not just prevention in terms of recognizing at-risk young people, for example, or prevention initiatives that happen and start in schools, but also tertiary prevention, prevention of something coming back and showing up again. So, for example, Medicare disincentivizing rehospitalization by wanting to charge hospitals more if somebody comes back for the same condition, things like that, right? Person-centered individualized care, a real outcome orientation, whether it's improving the experience of care, improving the quality of care, and of course, changing the cost curve and really reducing costs. That's your triple aim, if you haven't heard that before. All right? How's that for a summary of where we are right now? So far, so good? All right, now, I want to talk about communities of color for a moment, because that's still something we haven't quite addressed well, nor have we attended to it well, even. So whether it's been addressed in some areas, we're seeing pockets of attention, but whether it's higher rates of obesity, diabetes, cardiovascular disease, metabolic syndrome, rehospitalization rates, just in New York State alone, 3 to 4, African-American men, young men in particular, are hospitalized in New York State for psychiatric conditions 3 to 4 times more than anyone else. So, and we're talking about just rehospitalization without access to more integrated services and supports. So it just means that people are going into a locked ward, getting some acute care, getting maybe some initial support, but their discharge plan doesn't do much more than discharge them back to their car or a homeless shelter. So we're struggling with finding recovery-oriented outcomes in that regard as well. So we're wanting to see that change. Part of what that means is looking at the measures around these inequalities when it comes to new financing structures like DSRIP and the managed care structures that we're seeing across the country. All right, so I'm going to try to refer to New York here occasionally, here and there, but I'm going to be talking a lot about the nation as well. So what does that mean for the overall program? Well, that means that we need to call for collaboration. This has been basically the major underpinning of a lot of these reforms is we got to get out of the silos and recognize that there are communities that have yet to collaborate, much less integrate. So one of those issues that really clearly demonstrates that are the social issues: poverty, discrimination, housing, employment, healthcare. These aren't issues that can be handled by one silo alone. Addiction and mental health, whether it's recovery communities or your actual systems, have not collaborated well, and we haven't found a way to do that. So we needed to look at that at the policy level, programmatic level, organizational level, individual level, health home managed care networks, of course, integrated health and behavioral health, even research and community partnerships. So drilling down in some of those areas, if we just talk about mental health and addiction recovery communities, one of the areas is this conversation we're having today about harm reduction and abstinence-based recovery models. So I'm kind of putting that in the context of these areas of collaboration that have been needed in order to address these broader public policy and national kind of issues we're facing, and of course facing here today in New York. Make sense so far? Okay, it's kind of rhetorical. I know you can't really, if it didn't, I'd still move on. All right, so. No, I'm just kidding. If it didn't, please, if you have a question, write it down, or figure out a way to bring that to our attention. I'd like to be able to address it here, not find out later that I could have addressed something for you. So there has been a tendency to resist collaboration, and for a lot of good reasons. I mean, a lot of people have struggled with figuring out how to bring our systems or communities together. So even before getting into the conversation specifically about harm reduction and abstinence-based recovery models, let's talk about some of the broader issues around collaboration. One is that, we need to take a look at what are the consequences of going it alone. So, here in Rochester, there's a harm reduction community, and there's an addiction recovery community, there's a mental health recovery community. What's really happened as a result of going it alone? Well, we've seen funding kind of be competed for. We've seen communities lack the ability to hand off to each other well, or even recognize each other's value and support each other. Sometimes even serving the same people, not even knowing about it, right? Or not even knowing the outcomes that we're reaching. Or worse yet, stumbling over each other on that level. Some of the social issues that I mentioned earlier cannot be handled with one organization or system. They need to be collaborated about. There's some examples around how that's happening. One example is the Trauma Informed Community Initiative. There's a great resource out there funded by the Robert Woods Johnson Foundation, and it's called the Trauma Informed Community, and that's Community Resilience Cookbook. If you go online, you can see the Community Resilience Cookbook, and it highlights 9 initiatives around the country, and there's many more now that Robert Woods Johnson and the Philadelphia Foundation have actually supported that bring communities together around the understanding of trauma and the orientation of trauma. Recognizing basically the fundamental kind of premise being the adverse childhood experiences studies, and recognizing that, wow, when we look at our communities and the prevalence of ACEs, or those adverse childhood experiences, we see a direct correlation with the long-term social and health consequences that people are facing. All right, so basically in DC, Philadelphia, all kinds of places. Right now we just started one in DC, District of Columbia, and they're addressing a number of issues through the trauma-informed lens. So that's another example of ways to drive collaboration. I'll try to talk about those occasionally as I bring in these issues. So anyway, so some of the other issues we're trying to face are the slow pace of technology transfer, even bringing recovery research forward. I remember in 1985 was when the first journal came out from Courtney Harding around the 10 longitudinal studies on schizophrenia and the ability for people to recover, even that last third that nobody thought would recover and would always be in the state psychiatric system and in long-term hospitalization. Well, they did research on that last third and found that even 2/3 of that group were able to get off medication, get back to work, relate well to family, succeed in community. So the hopefulness of what's actually happening in the research work had not reached practice even 20 years later. And so some of that research to practice effort is still struggling, largely because of these silos, in my opinion. So, in any way, of course, independent kind of change like this is also unsustainable. We're not going to really be able to support each other to make all of that work. So one of the things that happened that SAMHSA did, and I want to applaud SAMHSA, not just because I'm funded by them, by the way, I was often a very strong critic of SAMHSA's efforts at times, but you know, one of the things that SAMHSA did was incorporate recovery into the strategic drivers over 10 years ago. And one of the things they wanted to do was bring recovery communities together to define recovery for themselves. And I bring this up because this is yet another one of those collaboration efforts that occurred, and this time driven by government, but also was happening at the community level. So in the early 2000s, maybe 2001 to 2004, they brought people in addiction recovery together to develop an addiction recovery definition. Then in 2005, they brought nationally people in mental health recovery together, and they developed a mental health recovery definition. And then they brought us back together. 2010 brought those of us like myself with co-occurring kind of issues together, along with the mental health. And I happen to run in both mental health and addiction recovery kind of worlds. There are many of us that came together, and we developed a consensus working definition on recovery that actually included the voices of people across many pathways of recovery. So whether it was mental health and addiction, those were kind of two big buckets, but it also included people on medication assistance, people who are moderate recovery advocates, for example, moderate drinking recovery advocates, all kinds of different kind of vantage points. People identified as consumers, those of us from the ex-patient movement or trauma survivor movement. It was just a real diverse community that came together. And over a couple of days, came up with a definition that looked like this, that recovery is a process of change through which individuals do a few things. One, improve their health and well-being, live a self-directed life, and strive to achieve their full potential. Now, I was here last year, I think, talking about this, for some of you who are here, and the idea behind this definition was to be inclusive of the recovery experience from many vantage points and many experiences. So the previous definitions of recovery, for example, that included abstinence, that was developed by CSAT originally in the early 2000s, was something that people on medication assistance really struggled with. They weren't recognized in that definition. People with mental health recovery kind of backgrounds weren't recognized. People with trauma experiences weren't recognized. So there was a need to have something that really acknowledged that. I mean, yeah, it's broader, but it certainly recognizes those kind of features that people wanted to see in a recovery context. So what did that mean? Well, it meant that regardless of what you've been through, that there was a vision for recovery, regardless of how tragic your circumstances were, regardless of how traumatic they were, regardless of how disabling the condition was, there was a vision and an experience and even evidence now that recovery was not only possible but could be expected. So what does that mean when we talk about harm reduction? That's something I want you to think about. So where does that fit with all of this? A couple of things that were involved in that recovery construct at SAMHSA is this home, health, community, and purpose framework. And I really liked it because one of the things we were trying to do was encourage our whole system, nationally, locally, everywhere, to have a quality of life orientation to recovery and not have recovery be the only markers be these kind of removals of symptoms or the removal of an experience like drug use, for example, or the removal of a psychiatric distress. All right, so the idea was that recovery could be something that included a vision for getting back to work, relating well to family, communicating with coworkers, engaging my education, pursuing new community roles, finding a sense of purpose, right? So, and then of course health and wellness and those levels as well. So that being the recovery kind of outcome focus, these were some of the guiding principles. Hope, that it was person-driven. Again, that many pathways perspective that came out as an explicit principle. That it's holistic, that it includes a number of different domains, not just one or two that might be prioritized by the system. Peer support, that recovery is a relationally healing process, that it's something that happens through a relational experience, that it prioritizes culture, that it recognizes trauma and addresses trauma, that it's about strengths and responsibility and self-responsibility, and of course about dignity and respect. So again, thinking about this in relationship to some of our systems, it's very interesting because we'd been trying to move our mental health and addiction and substance use treatment systems to just embrace these principles alone, right? And we started to see some action around that. What was happening? Well, trauma-informed services became more of a priority, for example, or we started to see hopefulness become something, or research on recovery being shared more regularly, or many pathways be supported. In the same way, we wanted to see that happen across harm reduction and abstinence-based recovery models. Now, this is, I don't know if you've heard me tell the story of the fox and the stork, but I'm going to tell it to you. Anybody heard the fox and the stork fable before? All right, this is my rendition, okay, of it. All right, it's a little spin on it. But the fox, if you haven't heard it before in Aesop's fable, the fox and the stork got together, and they were so excited to have become friends. And they were like, oh my gosh, how cool would it be to have a stork as a friend? The fox was thinking, and the stork was thinking the same thing. How cool would it be to have a fox for a friend? So from a diversity perspective, this was just awesome. They were just into each other and loving it, right? So they invited each other over for dinner. The fox brings the stork over for dinner and puts out a plate and has milk on the plate. I'm not sure where the fox gets the plate, but the plate's out, and the stork's just watching the fox lap up the milk on the plate. And the stork invites the fox over for dinner, and the stork has this nice, beautiful vase that she has fish at the bottom of, and she's able, because of her beak, able to reach that fish, while the fox, of course, could only watch. So this story is a simple story, but reflects the challenge that we have when it comes down to bringing diverse pathways together and trying to organize a way to actually work well together. And we can't just invite each other over and expect to really get to know what's needed or actually meet each other's needs. The same thing has been true around bridging the gap between harm reduction and recovery movements. Now, I have to say, it's been interesting because there are some great examples of where that's actually started to happen. Whether it's here in Rochester, as you mentioned, in other areas, there were conversations about this. There were advocates who were interested over the years, including myself back in the 80s, around trying to support a recovery orientation that actually looked at, well, what does this mean from a perspective of harm reduction? Have we brought in harm reduction into the conversation? It would start and stop. So Neil Hunt, this is a quote from Neil Hunt, one of the researchers that looked at some of the collaborations that were happening. And the basic premise of this quote is that there needs to be an ability to consider that the possibility that our worldview and the cherished concepts we use to describe our worldview may need to become more subtle, more fine-grained, and amended or even discarded. Wow. That's pretty powerful stuff. I mean, to consider that I might have to, in order to consider this, discard some of my ideas or worldviews. And that approaches which don't work for one person can equally be life-saving for others. That was really the point of the bridging, of the idea of bringing these worlds together. That maybe somebody's life might be impacted in a way that maybe, mine may not have affected mine the same way, but maybe it would help somebody else. When all the time our own beliefs, experiences, and perhaps our own entire biography shouts out that it can't be so. Now, that was my story, too. I mean, I interacted with a man named Walter Ginter, who's one of the lead national advocates for medication-assisted recovery. And when I finally got to know Walter, he explained his story of being on methadone maintenance and how that had been what allowed him to be the executive director of the medication-assisted recovery program for 20-plus years, and that this was the life that he wanted to live, and this was his choice, and this was something that he was pursuing. Harm reduction advocates that talked about the way in to services reminded me, that said, hey, wait a second, harm reduction never presumed the abstinence as a goal, but it also never excluded abstinence as a goal for recovery. So that was something that a lot of times when harm reduction and recovery advocates got together, the polarizing debate became about the stuff that we each other weren't doing, right? And that we were challenged by. But when we talked about some of the shared ideas that were actually happening, some of the harm reduction basics that people needed to hear about were what we brought forward. So here's one. One is that harm reduction itself, if you haven't known this already, is a combination of a philosophy and a policy framework, yes, but also a menu of services that are aimed at minimizing harm to self, others, and community. These largely happened in the early 80s, especially around, in terms of broad implementation around reduction of alcohol and other drug-related conditions, especially HIV and AIDS, viral hepatitis, and overdoses. All right, so when we were trying to reduce the impact of those situations and conditions, major initiatives like needle exchanges, for example, and syringe exchange programs were making a difference. And we needed to acknowledge that. Just as an aside, by the way, for about maybe now almost 30 years now, the federal government had banned the funding of any needle and syringe exchange programs, and only just this year lifted that ban. Out of recognition of the incredible overdose. So even people in Congress who were staunchly opposed to federal funding going to needle and syringe exchange programs, one in particular from Kentucky, a very strong conservative, realized, whoa, wait a second, I've been watching families and listening to families struggling with overdoses. I'm willing to change my mind about this. Maybe we need to allow federal funding to pay for them. They're not going to pay for the actual needles, which they've never done, but they're going to pay for staffing, they'll pay for program implementation and all of the work at that level. So that's pretty interesting to see that change. And then finally, in the harm reduction movement alone, there's a controversy around what level of advocacy should we be taking, especially at the population and person health area of intervention. So, for example, is it about drug decriminalization, decriminalizing personal drug use, for example, like they do in Belgium, has been an engagement outcome, right? We're seeing legalization in this country already. So what's going to be the outcome of legalization efforts, and what does that look like for addiction and especially for harm reduction collaboration? All right, how am I doing so far? Guys with me? Okay. Any questions coming in? Actually, Ann just left, so we won't know for a little bit. For those of you who are typing those in, I'll see if we can receive those shortly. Any questions or comments thus far? Yes, ma'am. The question was, do we know anything about outcomes around legalization in particular? Not yet, no. I mean, so what we're seeing...
How it compares, are people able to recover more easily in those places where it's legal or not?
Right, yeah, and that's a great question. So that's... Yeah, no, we're not necessarily seeing research at that level that's actually happened yet. So right now it's really at the implementation stages, and you'll start to see proposals for that research. I'm familiar with interest in that research area, but it hasn't happened yet. Any other questions? Okay, so I'm going to talk about some approaches that have happened to actually integrate harm reduction and abstinence-based recovery approaches. All right, so again, as I mentioned earlier, the recovery orientation has been an organizing framework for mental health and addiction recovery communities in and of itself, right? So even without a harm reduction focus, there's been an increased kind of sensitivity and willingness to engage multiple pathways. There's been a recognition of person-centered practice. There's been a recognition of trauma-informed care. There's been a recognition of cultural competence, right? So all of those things that you've already been showing up in your services and in your work and in your organizations really lends itself to this conversation. But in Philadelphia, they made a much more explicit effort in order to integrate harm reduction and abstinence-based recovery models. Now, I want to say, kind of like Rochester, Philadelphia has a strong history in both movements. So the addiction recovery and treatment community started, a lot of it started in Philadelphia. Benjamin Rush, a lot of the hospitals that were supporting addiction treatment, a lot of the initial kind of early foundation builders around addiction treatment occurred in Philadelphia. Same thing was true at harm reduction. A lot of the early harm reduction organizers and founders of service started out in Philadelphia. And they started out and basically remained for many years as silos in and of themselves and have movements that really opposed each other in some respects. In probably 68 to 70 is when methadone maintenance started to emerge, and the first treatment programs for methadone maintenance started to show up, and this is when the conversation started to get interesting, right, for us across the country as well. And so in Philadelphia, what they've done, fast forward to today, is brought those communities together, and in many places and organizations and actual systems, they have programs that have done a few things. One is something called assertive outreach. That means having people go right out into the street and really reach out to people that are not just reaching out from a harm reduction perspective, but are reaching out as part of a service array or part of a menu of services. Very exciting stuff. There's this thing called low threshold service access points. So what they mean by low threshold service access points is instead of having an access point that might be reflected by an intake assessment at the Evelyn Brandon Health Center, for example, right, which is a walk-in, we have walk-in capacity, all kinds of great capacity there, but the low threshold might be a service access point that's actually on the street. Or it might be at various levels of drop-in. So there might be different points of contact or engagement. So instead of having a centralized intake, there were multiple points of engagement that allowed somebody to engage where they were at. Okay? Recovery-oriented methadone maintenance, as opposed to just methadone maintenance, meant that a lot of the methadone maintenance programs also had things to look at when it came down to engaging their community better, right? So whether it was the times and locations of their services, the availability of more hope-filled or quality-of-life-filled or, work-oriented or, other kinds of, life-oriented or quality-of-life-oriented services, those methadone maintenance programs started to consider that more, including the use of people in recovery, people who are also identifying as on medication assistance or who have been part of the recovery communities in those areas. So a number of different initiatives occurred to bring those communities in, and that became part of the program. Needle and syringe exchange programs. Housing support continuum was another part of it. So that meant not just having housing, what we call dry housing or sober housing, but also having damp housing and wet housing. I understand that might be some interest in Rochester as well. So having a continuum of housing supports allowed people to be engaged at multiple points of their experience, or to engage people who would never have engaged in the first place, right, essentially. And then, of course, free medical care, the ability to have people, whether it's in homeless shelters or on the street or in another point of contact through these engagements, to be able to get access to health care. A lot of times right now, so for example, with the homeless community, there are point-in-time studies that happen in January or so. January 28th, I think, is the date that we do them. And that was a point in time. Those point-in-time studies were also an engagement time, right? There was a time to kind of offer somebody some support or services, depending on what city you're in. Now, Rochester actually, I don't know how this year went, but we've actually had 100% homeless engagement rate when it came down to everybody being in a shelter, according to the point-in-time studies, as compared to other states. We're one of the smaller cities in that regard. So everybody's engaged in a homeless shelter, or in some kind of homeless support service, according to the point-in-time studies, but they haven't necessarily been engaged for the kind of broader social determinants of health that are needed. So let's use an example like childhood services. Children who are in poverty, there are 1,500 to 2,200 children in poverty that are considered homeless as well in Rochester. So that's not necessarily reflected in that particular effort. The story I want to tell you here about this Philadelphia story is that it wasn't just about services getting together. There was a city-level government initiative. So Arthur Evans, who was the commissioner, Roland Lamb, who was the deputy commissioner, along with impressive leadership at the hospital, at the community program level, came together to really bridge these gaps and brought communities together to actually talk about the differences in their approaches and actually examine what they could do together. So it wasn't just about starting a new service and just hoping people referred to it. It was about having a policy framework that really looked at a few things. So let me talk about that a little bit. There were some common ground elements that they discovered in their discussion. One was and this might be no surprise to you based on everything I've said already, is that they had an engagement approach, an outreach and engagement-based approach, not a compliance-based approach. All right, so what is it, somebody tell me, what's the difference between engagement and compliance? You want to take a shot at that one? Yes, ma'am.
I think engagement precedes compliance. Engagement to me sounds like you're just sort of initially working together. They may not be compliant with like what the program is, like abstinence-based or showing up every single time. But they're connected in some way, shape, or form if they can't follow all the things that we're talking about. Okay,
so engagement is about connecting in some way, having somebody get connected. Any others? Great. Any other thoughts on engagement versus compliance? Yes, ma'am? That's right. So you're meeting someone where they are at that point in time, and as opposed to compliance, which is talking about what? If you contrasted that.
Requiring them to be somewhere they're not ready.
Okay, right. So a treatment plan that somebody needs to be compliant with is, that may not necessarily. So even the language of compliance requires that I'm kind of using an external standard. It's not my standard, is it? Right. So it actually doesn't come from me. It's not driven from something that's important to me. So the idea of a conversation around engagement means asking people questions about what's important to them and following through on what might be important to them at that particular time. I use examples from my own, as was mentioned, I worked here at Unity when we opened the Evelyn Brandon Health Center, and prior to that, some of the people we served, I was really happy to see that we were serving people who normally didn't engage services. It was very exciting to be right in the community and supporting people at that level. One man was referred to me, came to my office, and we were starting these intensive psychiatric rehabilitation treatment programs. They were the precursor to the PROS services that you see today. And at that time, he said, first thing he says, look, I know who you are. First thing I want you to know is you can't stop me from getting high. Right? That was the first thing. He just came right out and said it. And I said, wow, all right, well, tell me more about that. Why is it that you needed to tell me that first? He's like, well, I know you're somebody that's in recovery. I was well known in the recovery community already, and that you're somebody that's abstinent, and that if you're going to push that on me, that's not going to work for me. Right? And I said, well, I'm glad you brought that up. That's not what I'm going to push on you. I'd actually like to hear about what's important to you. So as we proceeded in the interview, what was important to him was getting a job, getting back with his family, connecting with his community, right? A number of things, none of which included reducing his level of drug use, right? Now, you could see a relationship between any of those things and possibly achieving those outcomes, right? However, that wasn't something I was he was willing to engage with me about. So I said, well, as we proceeded, I said, these are things I can definitely help you with. I wanted to know if we can talk about that drug use thing you told me. He's like, hey, I told you, I'm out of here. I'm not going to talk about that. I said, okay, here's the thing. I didn't need you to set a goal around it or have it be something that we, talk about every day, but would you be willing to talk about it once a month just to check in and see how that's going for you? I'm not trying to change it necessarily, but could I at least include a check-in and see if that's still something that's okay with you or if it's something that worries you or affecting your goals in any way? He said, you won't hassle me? I said, no. I said, okay, yeah. And so that was the conversation that he allowed into the treatment plan or into our service plan at that point. So that's an example, not necessarily, maybe not harm reduction. I didn't frame it as harm reduction. I didn't rationalize it in my progress notes as harm reduction. It was simply a priority for him, and certainly included a priority for me, right? So just like any other red flag that might be worrisome for me, whether it was violence in the home or self-injury or drug use and unemployment. I mean, I bring unemployment into that same clinical zone of priority. If somebody's unemployed for 6 months or more, they are just, what we know by the research is that they are much more likely to have increased mental health issues, isolation, drug use, right? Physical health issues. So I tell people about that and say, hey, you know what? You've been unemployed for a long time. Is that something you want to consider addressing, right? At the same kind of level of clinical concern and anything else. So anyway, that's an example of some person-centered assessment and treatment planning mixed in with that engagement conversation. We don't have time to get into all the competencies associated with that, but that's an important training area and supervision area. Yes, ma'am.
How did he do?
He did great. He did great. Yeah, it's a great question. I mean, by the way, not just him, but others who were involved in those conversations, things like, you know, we're able to get back to work. We're able to address and actually say, you know what, I think this is getting in the way. I can't even do a drug test, you know, things like that. Whatever it was that was happening in community, I was no longer an enforcer, right? I was now seen as a person aligned with his goals and there as a support to him in those circumstances. So that was what we wanted, right? Somebody to be standing next to us, moving towards what they want to achieve, not feeling like we were opposed to something that they wanted to achieve. Thank you for asking. Any others? Yes, ma'am, in the back.
So I think that's a really important point, just in terms of harm reduction and abstinence. Because it sounds like potentially maybe that conversation led him to have some abstinence at some point.
That's right. That's right.
And you know, but that opened the door.
That's correct.
And we see that a lot in the program that I work in, that just opens the door. The abstinence may be the eventual result or goal, but it doesn't always have to start.
So, and thank you for raising it. So the opening the door, I think, is a great set of words for what we're hoping for by harm reduction conversations, as far as the system is concerned, but even as a practice, really recognizing that, well, you know what, this may not be just from a stage of change perspective what somebody is willing to engage, right? And so am I willing to adjust and adapt my approach, or what I think is important at this point, to walk with them towards it. And even dropping abstinence programmatically might be a challenge for some of you who are already, we don't have state licensing that has actually allowed you to do that necessarily, right, in terms of your regulatory framework in some respects. So that's okay. That doesn't necessarily mean you have to force it into every conversation either. So there's ways that you can actually bridge those conversations. Trauma-informed approaches, same thing. Having an assessment process that doesn't leave somebody feeling like they've just been asked what's wrong with them, but is being asked what's happened, right? And what's happening, so that somebody can actually bring those experiences forward and feel more like that matters to you and to the system they're being engaged by. Attention to community roles, being concerned with whether somebody's a mother or a father or a sister or a brother, or whether they're a son or a daughter, or whether they're employed or unemployed, or whether they're a student or not a student, whether they want to be. So attention to all of those things were very much a part of harm reduction models. We just didn't see that. Everybody thought that harm reduction programs, especially if they were looking at it from the abstinence-based program model, they were thinking, oh, they just have such lowered expectations. They're not asking people about that. And in some cases, they weren't. So harm reduction programs started asking more, in this Philadelphia example. They started to consider recovery-oriented outcomes as a priority, just as much as the abstinence-based programs did. And then, as we said earlier, a recognition of multiple pathways. So some implementation examples for you to consider. These are just a few. There's a bunch others that you can really look at. And we'll talk in more detail about any ones you're interested in. But one is engaging people at earlier stages. So we just mentioned that. So the more you have exclusionary criteria that are specific to a particular stage or level of care, the harder it is for that person to kind of consider whether this is going to work for them. I got a call from another man here in Rochester who's trying to help a young person, a young black man in his 20s who's, using marijuana, has serious mental health issues, physical health issues, family issues, legal issues, but does not want to engage the system yet. But he's willing to talk to me. So that's why he said, can you talk to him? So that's all he's willing to do at this point. Text me and talk to me. That's about it, right? So what does that mean? Well, it means that's where we're going to start, right? And so we'll see what happens from there. Do we have an infrastructure that allows us to do that is the next level question, whether it's in your program or service or system. Right now, the most of that infrastructure that I have is a bunch of phone numbers in my back pocket. That's it. That's all I have. And I try to have that for every city I move to, because I get these calls all the time. I got a call from a young man in Glens Falls, New York, who was holed up in a hotel room. His father's willing to pay the bill for the hotel room just to keep him safe, but he's been, just sitting in that hotel room for 2 years with nobody to engage him, right? So these are the kinds of proactive measures that we could actually kind of do something about and consider. All right, engaging people who have traditionally rejected support or cycled through acute care. There's a definite understanding there, right? So we're seeing people that will reject care. We're seeing people that would cycle through acute care and just only address acute care issues. But when it comes down to longer term kind of support, that needs to be further defined for them. Lowering access barriers to stable housing. So that's why the housing first options that we were talking about are being considered, whether it's having exclusionary criteria be dropped altogether and just be concerned with stable housing and not be concerned with all of these other requirements, or whether it's having a mixture of housing options that can allow somebody to come in. Now that, by the way, is probably the single most repeated kind of recommendation when it comes down to this opportunity to integrate harm reduction and recovery models. Health and social supports, welcoming and open readmission processes, having somebody be able to come back in. I was recently informed about a young man who is actually from Rochester, but he's a teenager in treatment in Albany, and he basically, they call it, went AWOL with the other teenage kids in the program. Left the program, which is a long-term residential adolescent treatment facility, and broke into a bunch of houses and cars and that sort of thing, and then finally found a car with some drugs in it, and the other kids proceeded to use. He realized what was happening at that moment, got to a payphone, called the residence facility, and said, "I want to come back." Right. Now, when we talk about the question of engagement and compliance, I see a young kid who's suddenly engaged in his recovery. Yet the policy of that program had to remove him and discharge him. Right? So it was a disconnect between what we see as engagement and what we experience as engagement with what kind of policies we're experiencing at that level. Administrative discharge policies are an example of that, so revising that and enhancing these linkages between our programs, creating more integrated kind of opportunities and conversations between us. I'm sorry if that cut off there. It's just a continuation of that continuous integrated care, is my understanding. Did I forget something on there? Somebody want to read to me that last bullet?
Elevating visibility recovery.
How could I forget that? Thank you. All right, that was a setup, wasn't it? Right? So, so one of the things that people have often struggled with, including our systems here in Rochester, is how to elevate the role of people in recovery and people in multiple pathways of recovery in our community. And a lot of times that's resulted in policies, for example, that tell people not to disclose, worries around people using their experience as the only kind of way to engage people, which is also not necessarily the way to go. A lack of clarity around what self-disclosure really means and looks like and what the criteria for that might mean. And then the real role of representation and how that can actually make a difference. So there's kind of a combination of needs going on. So it's not just the emergence of and the utilization of lived experience in our service structures, such as peer recovery coaches, peer support specialists, people who happen to be in recovery and are hired as clinicians, things like that. But also about the identified representational leadership. So that means people seeing an organized entity kind of in Rochester that represents people in recovery, or seeing that, oh, wow, being in recovery is actually celebrated. Or Chacku doesn't talk about it like it's something to be ashamed of at all. He keeps saying it all the time. He's not, it's partly because I've been out, I was outed by the papers, a long time ago. I didn't have much choice at that point. But we decided to celebrate that by doing presentations and talking about the need for recovery-oriented services. So elevating that as an implementation standard isn't something you can do on its own, and just depend on that alone, but we do want to look at that as part of the continuum of effort. All right, so this is going to, oh yes, sir. Thank you.
Yeah, on that last slide, and you talked about implementation. Well, one of the things I was thinking about when they talked about enhancing linkages between harm reduction and abstinence-based treatment and recovery, a lot of times in the facility I work at, we might give a recommendation for a client to go into community residence. None of the community residences practice harm reduction.
Right.
It's all, so
right.
I'm saying that, it ties in with what you talked about earlier.
That's right.
kind of getting on the same page. I can't think of any community residences that would follow a harm reduction model.
So currently you don't have that option, is what you're saying, to actually have somebody go into a residence and not have to be abstinent in that residence. And that's exactly what we're talking about, is that there will be a need to bring a group of organized partners together and say, what are we going to do? Are we going to change this continuum for housing in order to be able to not discharge somebody into the street again, right, or into the shelter system just because they're using, right? That seems like, based on this conversation, like a loss, right, and a waste of effort, if we've already engaged somebody at that level. Thank you, sir, for raising that point. So let's hope we can have that conversation. I mean, so I guess what I want to do is help you address some of the things that might come up as objections. Part of that effort has been looking at some of the shared interests. So one is, some harm reduction advocates often would say, you can't help somebody recover who's dead. And that's the kind of the hardest point to really engage, I'm a suicide attempt survivor. I'm a drug overdose survivor. I'm an ex-patient here at Park Ridge Hospital and in a number of services, mental health, addiction, detox treatment, in and out of stuff, struggling. My family struggled. My wife's in recovery. Faced death many times. Now, my family would love to believe that you were more concerned about keeping me alive, right, than just some exclusionary criteria. At the same time, they were also very worried about lowered expectations. So if you also weren't helping me get back to school or helping me have a broader or deeper vision for myself, they were also upset about that, right? And because sometimes people were said, oh, just be happy he's not trying to kill himself or anyone else. Stop worrying about that other stuff. Don't worry about that he's smoking now. Don't worry about, So they were coming back, well, when is he going to go back to school? When is he going to get a job? When is he going to be able to handle life beyond our support, right? Be self-sufficient. So they're still asking that, by the way, and I even got married. And so I'm not, I'm not sure, how we're doing, but I'm getting there, But I think I cut my hair finally. For those of you who know me back in the day, So that suddenly made everybody happy, and they think I'm in recovery. I didn't know that was a recovery domain, cutting your hair, but it apparently is. So I think the hope is that we can actually engage people in that conversation. Well, we can also engage new outcomes. So if the outcome orientation for harm reduction has always been a reduction of harm, minimization of harm, or reduction of kind of negative stressors, well, maybe we can ask harm reduction programs to increase outcome orientation around other things too, right? So to measure the adding of things, whether it's quality of life outcomes, whether it was promotion of health outcomes, the identification of those things. And the same thing is true for our addiction recovery communities and services, to look at outcomes that are also about minimizing harm and minimizing those damaging effects. Well, one of those things to enhance are coping strategies and increase social supports. If there's one thing that we can support everybody to do, is increase social capital or even assess social capital. So I asked a young man who was homeless here in Rochester, I said, who do you have that has your back? That's all I asked him, right? And he said, so-and-so on the street. All right? And I said, okay. His name was, the guy on the street, his name was Cuba. Cuba on the street has my back. I said, well, how does he have your back? He said, he's kept me alive all this time. That was pretty compelling. Right? So for 5 years or so, this other guy was the only person who this person would identify as keeping him alive. I said, so that's been important to you? Absolutely. What else is important to you? And so we started to evolve that conversation about what was important to him and who else he would like to bring into that social capital of his. But he was getting to see people in his life as part of that capital, part of his strengths experience. All right, so anyway, this last point there is that harm reduction and abstinence-based recovery models do not have to be opposing strategies. In fact, we see them as ways to bring together, ways to actually reach new populations you haven't been able to reach, people with the most complex concerns and conditions that we haven't been able to engage in our own services thus far. All right, or we've got what's our what's our stay rate? 1 visit on average at this point, at best. So we're seeing people come in for a visit, leave, and never come back until we get back to another acute care kind of crisis level circumstance. So we don't have a re-engagement rate that's pretty strong yet. So this is one way to engage that. Reaching people who are at different stages of engagement. So the same person who the cops and the fire department and the ambulances have been picking up on the street now, we might have a new continuum of engagement for that person, right, that actually helps them engage care. And I can tell you law enforcement's going to be much happier about that, including community supervision. I am glad to see here as well probation and parole and other representatives. All right, so in the interest of time, I want to kind of get to some final points. One is that I just mentioned it. We're going to be able to address these multiple, severe, complex conditions. These are often intergenerational conditions, by the way, and sick experiences that people are facing. It's not something that is kind of just a one-time individual set of outcomes. We need a family-based, whole family, whole health approach, one that's really engaging the whole community that a person considers in their life, even if they haven't seen that person for 20 years, right? If they have a mother, we want to know about it, right? If they have a sister, we want to know about it. The ambivalence and resistance that people have starting to change our conversations in supervision and in team dialogues, instead of just seeing that as another opportunity to blame the patient, if you will, which, by the way, healthcare should never do. Healthcare, we should never be blaming the people we're serving for their lack of engagement. That's on us.
I'm sorry, the ambivalence and resistance coming from the patient or the...
Oh, I'm sorry, coming from the patient, correct. Exactly. Or the potential, person who's not even a patient yet, but still out on the street. So the resistance and ambivalence of somebody to engage support and services is natural, not a pathological experience, as many would like to actually perpetuate. We've come up with all kinds of ways to explain things through a pathological, biological condition, yet that's not quite, the evidence doesn't show it that way. It's not what we see. Resistance and ambivalence are reduced when people actually have choices, when people have opportunities to make choices. All right? So when we consider those. Recovery can be achieved with or without medication. So that's an interesting kind of dilemma that we've seen in our system. So a lot of the advocates for abstinence have said, wait a second, you're just pushing medications way too fast. All right, I'm seeing young people only getting medication offerings and not getting anything else. All right, so whether it's in mental health on first episode psychosis or in addiction psychiatry, we're needing to actually have the conversation and say, well, what else are we doing? All right, what else can we do first? Instead of starting with medication and pharmacology only or alone, can we include other conversations? So we're seeing that happen in New York State actually already with our first episode psychosis and co-occurring integration of care processes, especially with On Track New York and New York City. So if you want to see some examples around how open dialogue, intentional peer support, kind of good housing programs and respite programs come together around a harm reduction model, as well as a kind of overall recovery-oriented approach, that's something to consider as well. And then at the same time, if somebody does choose to have medication assistance for their recovery process, whatever age they're at, are they getting a kind of a fair shake of information around what's available to them? So, for example, let's use methadone. What does it take to get off of methadone? What's the process? As well as, here's what it takes in order to stay on methadone, if that's what you choose as well. So what does that look like for somebody? A friend of mine just celebrated his second year off of methadone maintenance treatment program, and he's choosing to celebrate that as something that's important to him. That doesn't negate all of his friends who are in recovery that are on methadone today, right? Or on any other medication assistance for their recovery. That also doesn't negate 12-step communities who want to maintain their standard as well. So if a 12-step community says, well, we're abstinence-based, but we're welcoming, then that's what they are. They're more sensitive today, which is great. I'm really seeing nationally and even in this community an increased level of sensitivity and welcoming and inclusion of people on medication assistance in 12-step programs. However, they still have their kind of lines in the sand, if you will, around leadership roles or representation of an abstinence-based program, right? So for those are the kinds of ways in which you can operate as well, where you can say, well, this program is an abstinence-based, or this is an abstinence-based housing program, which we want in order to help people feel safe and secure about their choices in recovery to be abstinent, right? And then we have over here what they call damp housing or wet housing for people who are still trying to figure that out. All right. I promised in the interest of time that I'd summarize some of this stuff, but here's what I'll do. These are the kind of lessons learned at the administrative level and policy level. If you're going to bring people together, let's do a couple things. I'll just highlight a few points. One is make sure everyone's kind of voices are heard. So if you're only going to train about harm reduction and not about abstinence-based kind of models that are recovery-oriented, right, you're going to kind of worry the communities that are concerned about the integrity of their support and service. And we don't want to do that. We want to have that be part of the cross-training approach and the integration and the diversity that you're building. You want to have that cross-fertilization across relationships occur. So that means have people get to know each other. Instead of having, I don't know how many meetings you've had with harm reduction community advocates, and maybe they're here. If you're here, how many of you have invited addiction recovery or abstinence-based programs to your circles, right? So those are the kind of combined conferences, or if you're going to have a conference this year, I'm excited to hear that, maybe invite a conversation with harm reduction advocates and programs in order to do that. Science certainly helps, and so we're certainly recognizing here that harm reduction, the evidence around harm reduction, for example, all the complaints people had, well, you're just enabling, people are just going to stay on drugs longer, people are just going to die faster, none of that has been demonstrated in the evidence, right? So we can say, yeah, the science has helped show that harm reduction actually has been helpful, we've been able to save lives, we've been able to minimize harm, but we also want the stories. We want people coming out and sharing with us what their experience has been, both whether it's in the ER or whether it's in our services or whether it's in the hospital or whether it's in the community, about how harm reduction and recovery integrating has really made a difference for them. And finally, financing-wise, this is going to be a tougher conversation, but we need to bring those forward with our policymakers and funders around having funding opportunities for both as opposed to having to compete for the same pie, right? So if you're going to try to expand the continuum, this is the time to do it, to actually make sure managed care communities, the state, your county kind of implementation plan here actually considers what you want to accomplish there. So lastly, the point is that this is a win-win. This is not an either-or. This is a yes-and recommendation. I'm not necessarily speaking on behalf of the federal government or SAMHSA or any other entity in that regard. That's all of those conversations that we're having that you heard me say are conversations that are happening at those levels and are being considered. We're listening to you now, though, about what the complex concerns might be. So one example might be, how do you negotiate levels of care? How do you refer people? How do you intake? How do you do assessment, at this level? What does that look like, right? What does that mean for another level of cross-fertilization and collaboration in your already intensely interdisciplinary focused teams, right, that you have today? So I guess I'll stop there. There's a number of references that I included there. There's many more. I'm excited to say that the literature is quite deep about this, so you can probably check it out, and you'll see everything from provider perceptions about this abstinence and harm reduction conversation to papers by William White in particular. I'd like you to check him out. Bill White is a colleague and somebody who's written. He's kind of the poet that, as well as writer and researcher, that has really brought together a lot of the recovery history and addiction recovery history together. Arthur Evans and Roland Lamb's work, as well as something worth considering as well. All right, and then check me out at Consumer Star. Any questions from the field, from the satellite sites, or for the audience here today?
Hi. So I read about something. I'm just curious about your thoughts
Yes,
about
sure.
it. I'm not sure how accurate my description is going to be because it was a while ago, but I read it. But essentially, there's a place in New York City that's like a mental health respite. Like if you go in there and you say, you crash up to 30 days there, you can basically take like a timeout from life without having to go to like some intensive hospitalization ward.
That's correct.
Check into the about thinking of like low threshold and accessibility and engagement, like what your thoughts are about that style of intervention and the ability to perpetuate that sort of thing that's effective.
Absolutely. So thank you. So the question was, what are the, what's my take on some of the options like the respite houses that are available in New York City that you heard about. So first of all, I am very much a proponent of those respite services. These alternatives to hospitalization and diversions for hospitalization are, we had them in peer-run communities that started in New Hampshire and have now kind of shown up all over the place. There's a great model here in New York. Steve Michio from the People Incorporated started called the Rose House. The model you're talking about in New York City is called the Parachute Program that also includes a connection to the community access, which has a number of respite programs that are available there. These respite models have not been available yet here in this area, and they're something worth considering. Many people have wanted to see it happen. The idea that people like about them is that they are low cost and prevent a lot of high cost services, right? Hospitalization, emergency room, and crisis services. And then it's a connection to peer and recovery-oriented staffing that can stay, connected with you for a much longer period of time. So yeah, it's made a lot of difference in the lives of many people. Yes.
There is one here called Vinny House by East House.
Oh, I'm sorry. You're right, East House. Thank you. Oh my gosh, what was your name?
Mine?
Yes. Becky, thank you, Becky. East House would probably kill me for not mentioning theirs, right? So those of you who are here from East House, my apologies. East House has started a peer-run crisis respite, the first of its kind here in this area. For more updates, speak to Becky, because obviously I'm behind. My apologies. Yes?
We work for Health Reach, providing health care.
Oh, great.
to homeless communities.
Excellent.
We do have an assertive outreach program.
Yes, you do.
And we also do low threshold service.
Excellent.
And we do monthly sweeps, looking for people that are homeless. We're trying to gather them up and bring them into the clinic.
Yeah, I saw when I was bringing up point in time, you were doing the point in time studies, weren't you? So thank you. So we do have harm reduction folks right in the room, right, that are directly funded and supported in that regard. So thank you for being here. You're obviously connected already in this way. So that's why you're having the conversation here to take it to that next level. So I hope some of you consider, just starting a small coalition. That's what we did. That's when I was here working for Unity. I was given permission to kind of use some of the space to kind of organize a brief coalition on some of these issues, and I was able to put flyers in everybody's mailboxes when we had mailboxes and get everybody to come. So let's start considering some of that. All right, were there some other comments? Yes?
I have a question. What's being done to help broaden the understanding from law enforcement? And I know you mentioned probation and parole, into the understanding that people using aren't necessarily bad people and need this level of restriction and punishment as much as possibly some rejuvenation and some resurgence into benefits or lost benefits.
Yeah, great question, Chris. The idea has been presented, so the question was, what's been happening with law enforcement to help people not necessarily be judgmental about what they're seeing on the street, but really recognize the health issue that's in front of them, right?
Incarcerated,
that's right.
Up instead of just this constant.
That's right. So there are programs, everything from nationally, from the Office of National Drug Control and Policy, recognizing recovery orientation, the director himself coming out as a person in recovery, wanting to emphasize recovery as a priority, recognizing public health as a national framework, even from, like the drug czar, right, if you will, moving from an enforcement model to a health model that actually works in collaboration with law enforcement, and to locally here in probation's right here. You can say, gentlemen in the probation, the local county probation department recognizes that here in Rochester and Monroe County. And you also have a police department that emphasizes crisis intervention training for both mental health and addiction. However, despite all of those efforts, we still experience a social kind of fear and stigma and public perception that has continued and be pretty pervasive. So I presented a while back last year about those public perceptions, and they do translate into violence, in the street as well as concerns about violence from people, especially in shootings with police, right? So the issue of having law enforcement even be more engaged, what law enforcement will tell you is say, I don't know if anyone's here, but they'll say, we just want someplace to take people. You know, right now we don't want to be the first responder necessarily. If there's a better first responder, we'd be happy to have a better first responder. We only want to be called in if at the last resort, right? And even then, we're willing to be trained to negotiate better and to recognize the way to engage people more effectively. So we're seeing some of that happen more nationally, but I think we have some ways to go. Yes.
Well, Chacku, before we run out of time, I wanted to be sure to thank you for a really important conversation. I also wanted to thank these folks up here in the front, Steve and Paul and Ann, who are trying to make all of our streaming work. But I did have a question.
Yes, sir.
I was in Burlington when Bernie Sanders was mayor, going to medical school.
Okay.
So something about my age. And I took a elective during med school down in Boston with a harm reduction alcoholism program at Mass General. And a lot of people said, you know, why are you doing that? This is, this is something to be vilified, not embraced. And, you know, it's kind of, somebody made the comment earlier, you know, it's, here we are, more than 30 years later, still having this conversation. The issue hasn't gone away.
Not at all.
I just got an email today from someone in, I think, Connecticut, talking about an Excellus refusal of Suboxone for someone who had relapsed into opioids.
Because they relapsed.
Because they relapsed.
Yeah.
So my question is, in New York State, where we're nested, can we be hopeful that there might be some loosening of some of the thinking and some regulatory relief around some of these things that so tie us up? And we're not unique, but I was curious about that Philadelphia experiment. You know, I'm thinking how hard that would be to pull off in New York State. And I don't know if you have any.
No, I do. I think New York State is probably more primed than ever before for that experiment to happen. So I'm really glad you raised that. So whether it's the state policy initiatives, the State Office of Mental Health, OASIS, and Department of Health recognized 10 years ago that, you know, you were serving people with co-occurring addiction, mental health, and physical health issues who were costing the system 75 to 80% of the Medicaid expenditure, but were only 20% of the Medicaid population. You know, there was a recognition of a need to really reinvest Medicaid dollars in a way that would actually get out in front and upstream of these issues, and recognize that we were still cycling through these really high-cost services and runaway Medicaid costs. You have a recognition of Olmstead and a need to really bring community-level initiatives forward. It seems, a financing strategy that actually, even though hospitals are challenged by it, I mean, like your own, to really drive services into the community and to be part of what I would call a continuum of service rather than siloed kind of work, right? So the network capacity to actually add and to talk about, from a community perspective, a public health perspective, say, look, these are the social determinants of health. I've heard the Department of Health, Medicaid director and staffing actually use that word, use those words, social determinants of health, in their description of what the menu that they want to see supported. So when we're talking about services like this, it's a no-brainer. The managed care contracts follow that suit. So the next level is to get managed care conscious, and you mentioned one managed care company already, that at the insurance kind of planning level, they don't have it implemented yet. At the contract and policy level, they're seeing the writing on the wall that they need to better understand that, so they're calling more of us, including myself, for training and conversations at that level to really say, well, how do we do this? What are the quality metrics that are associated with that? So they are questioning that and would be interested. The business case is what needs to be made there. So that's a different case than the political case with the state. The state has kind of understood that. Now it needs to be, what's the return on investment for a continuum of service that includes these pieces? And I don't think we've organized that locally quite as well yet. It's not that it's not there. It just means add up the numbers. It means connect criminal justice, but I would just start with mental health, addiction, criminal justice, and maybe education, kind of metrics, and show the cost curve and bend in that regard. And you'd be able to do it. I think it'd be a great example. I mean, your Blue Cross Blue Shield right here would probably be a great place to start in terms of that conversation. I know it's being taped, so don't quote me on that for them. But I'd love to see that, and I'll be able to help. I'd love to help. Another point on that, if you don't mind me elaborating on that point, policy-wise, nationally there are the examples like the Philadelphia experiment. Those national leaders, like Arthur Evans, will share their experience with you. So they'll come and talk about what it took. And I'll be happy to help you bring them, for a conference or a small meeting or whatever it takes to do that. So thanks. Great question, yeah. Had more to say about that, so we'll wait for the next training on that. I know I don't want to be that guy that keeps you beyond 5 o'clock at all. I know you're here despite the notes you have to write, despite all the work you've done. You're champions to me. My family thanks you for all that you do. I thank you for all that you do. And thanks for including me in this conversation with you.